Good afternoon, everyone. So I am a South African medical doctor, but I'm currently working for the Centre of Global Health Research at the University of Oxford. And myself, Chanda Mwamba, and Andrew Kanike put together some implementation guidance for IAS on implementing person-centered care for people living with HIV. So I'm going to give you a little bit of an overview of what that is. No? Okay. Excellent. Thank you. So what do people want? There's a lot of evidence to show that there's a big demand for person-centered care, and people really want quality care that responds to their needs. So what is quality care? It's care that is efficient, it's flexible, it's provided by people who treat you with respect and dignity, and it's drugs that don't make you sicker than the HIV would. But not everyone has the same preferences for exactly how that care should be delivered. And so choice is a really important part of designing care that is centered around people. And while some people do want their doctors or nurses to tell them what to do, one study showed that about 75% of people want to have some say in that decision, whether it's making the decision completely themselves or just having a shared decision and having some input into what happens with their care. And if we do this, evidence shows that it improves outcomes. It improves viral load outcomes, it improves retention, and it improves satisfaction with services for both staff and clients. So what are the principles of person-centered care that we need to think through? Well, firstly, we need to see people as a whole person, beyond just their HIV diagnosis. So they're navigating these really complex lives where HIV is just one small part of it, and the health system needs to recognize that and respond to it. It also needs to recognize that each individual is unique and different, and we need to tailor services as much as we can to what that particular person needs and what that particular person wants and prefers. Services need to be integrated and designed around the people using them, not around what is easiest for us as the health system to implement. And they need to be delivered by people who respect and treat clients with dignity, but also acknowledging that there's a partnership. It's not just the client at the center, it is both the client and the provider that are the people involved in the system, and both need to be put in the center of person-centered care. So some of the approaches that we can take to implementing this and operationalizing these principles starts with the service design and organization. So this is things like integrating services across mental health and non-communicable disease and HIV. It's having options for people, and that's where differentiated service delivery comes in. So having different ways that people can engage with the services, and providing different options, including injectable antiretrovirals. So not everyone will want to be on an injection. Some people will prefer oral treatment, but we need to have those options available so that people can actually make a choice. Then we need to support the health providers, because many providers around the world are very, very burnt out. They're stretched, they're overworked, and now we're expecting them to take longer with patients and spend more time kind of considering where this person is coming from, and that adds burden to our healthcare providers. So we need to help them reconnect with that motivation of why they became healthcare providers in the first place, to help people, and provide them with the training and the support so that they can put that back into action. Another very important thing that drives implementation is data and what we measure. So we need to make sure that the data that we're collecting does consider the person-centeredness of care. So it's no good just looking at treatment outcomes. We need to make sure that the targets that we're aiming for include things that promote person-centered care, and that we're monitoring that and checking that we are being person-centered. And that's where community-led monitoring can come into play. Also, the more data we collect, the more evidence there is that person-centered care works, and it feeds back into the system to encourage people to implement person-centered care if they know it's going to work. We also need to support the interactions between clients and providers. So traditionally, relationships have been very skewed with healthcare providers being the ones in power. So it's really up to the healthcare providers to be the ones that reach out across that divide and change the way that the relationship is structured. They need to actively encourage clients to get more involved with decision making, to feel comfortable, to have input into how their health is designed. And that's where language is really important. So we need to move away from labeling people, using words like defaulter, and move towards talking about behaviors that are happening at this point in that person's journey. So saying that someone has disengaged from care, rather than labeling them as a bad patient, which is something that usually sticks for the rest of that person's engagement with the health services. And lastly, leadership needs to get on board. So leadership needs to create the right environment that it's easy for healthcare providers to do this. If your targets are seeing 30 patients a day, you don't have much room to take your time to consider all that this person may need as a holistic human and not as an HIV patient. So we need leadership to set targets that are realistic and allow person-centered care to happen, but also to provide the resources, the training, the feedback, the support to allow this to be implemented. And if we implement these activities, what we're doing is taking those principles and putting them into action. But always there are things along the way that trip us up. So there are lots of challenges that stop this from happening, whether it's lack of infrastructure or lack of resources, because you need clinic space, you need resources to be able to reorganize flows, offer different options, or the traditional very biomedical focus on what people need in terms of their diagnosis and their treatment. And so shifting that approach to considering these things that are outside of the health services is challenging, especially when providers are burnt out and obviously very resistant to change, which is very understandable. But there are lots of opportunities that give us things that we can leverage to put this into place. So there's more and more evidence on person-centered care, and that gives us options of evidence-based interventions that we can offer to people that we know are going to help them. It also means that funders, guiding organizations like WHO, IAS are using the language around person-centered care and expecting something different from researchers and from providers. And technology is moving forward, so it makes it easier for us to change the structure of our services. If you can task shift to counselors or nurses, and if you can use, say, electronic medical records to integrate care more easily. So the key messages really are that person-centered care isn't reinventing the wheel. It's not doing anything crazy. It's just putting people at the center of everything that we do. It does require some understanding and some thoughtful reflection on those principles and thinking through how the services that you are implementing align with them or don't align with them so that you can identify where you need to do the work. But it's really important to make sure that you're putting all the people involved at the center and not just the clients, because our healthcare providers need support, they need investment in order to be able to make this work. And lastly, this is a systems approach. It needs to be implemented at the macro level, the meso level, but there are lots of things that people can do every single day in very small ways that just shift care to be slightly more centered around the people involved and slightly kinder and more supportive. So I'll put you in the direction of the implementation guidance that's on the IAS website, where you can find some how to get started documents that might give you some questions that you can think through to get yourself going in the direction of person-centered care.